Um, it is 4:30 in South Africa, so we can start. I'm just going to share my screen. Right, let's start. I just want to welcome everybody to this, the first Hepatocellular Gecko, HCC Gecko meeting today. I had a look at the registrations just before the meeting, and if all attend that subscribe to it, there's going to be more than 120 people from 20 countries and either also continents outside of Africa. And it's really a true MDT mix of specialities, including surgeons, radiologists, hepatologists, oncologists, pathologists, and so forth. For those of you that are not well acquainted with the whole ECHO concept, I'll just give you a brief overview. So Project ECHO was started by Dr. Sanjeev Arora from the University of New Mexico in Albuquerque in 2003. And ECHO stands for Extension for Community Health Outcomes. And you can see part of the mission statement there. Really the mission is to democratize medical knowledge and get best practice care to underserved people all over the world. And the vision is to touch the lives of 1 billion people by 2025. And you can see here in 2020, the very sharp increase in the number of people that attended these meetings, and probably due to the COVID pandemic, but also that we got used to using these platforms. The ECHO model of care, if it comes to the telementoring program, really is based on 4 principles, as they are mentioned there: using technology to leverage scarce resources, to share best practice, to employ a case-based learning platform, and also to eventually monitor outcomes to ensure ongoing benefit. I think we really have to mention and credit Wendy Spearman and Mark Sonderup from the Liver Clinic here that really piloted this platform for us, starting a viral hepatitis meeting for Sub-Saharan Africa, if I'm not mistaken, already 2019. It was started with from Cape Town with a number of, it's a hub and spoke model that you run, a number of spokes in Cape Town, but also in 3 other African countries that I show there. And these have since the start of the project actually gone on to become hubs themselves with their own spokes. I had the privilege to attend one of these viral hepatitis meetings because there were 2 patients that were discussed, patients with hepatocellular cancer. We had a very nice, almost MDT discussion. It really became apparent that there may be, and I think there is a need for a forum specifically for Sub-Saharan Africa, where we can still discuss this very difficult problem. Just a brief overview. We know that it's the most common primary hepatic malignancy. Annual incidence and the annual mortality are not that different. And it tells us what the deadliness of this disease is. Just under 10% of global cancers are accounted for by HCC, 5th most common in males and the 8th in females. And it's a 2nd leading cause of death worldwide. But importantly, about 84% of patients will occur or will be from countries that are less developed. What is the situation in Africa? In some respects, it's very different. There's a very high prevalence in all Sub-Saharan African countries. It's the most common cause of cancer-related death in men and 3rd most common in women. And again, an annual fatality rate of 0.96. It tells you how deadly this disease is. But different in Africa, it occurs at a younger age. More patients will have non-cirrhotic livers. Patients in general are larger. And quite often these patients present with metastatic disease. The etiologies, and I'm not going to go through those, are well known and they may differ from country to country. But in Sub-Saharan Africa, main etiological factors, historically, chronic hepatitis B infection and aflatoxin exposure as well as dietary iron overload, but the other factors are sort of slowly creeping into the into the continent as well. We've got these nice algorithms that help us making the diagnosis, and we can make diagnoses these days in most patients based on imaging that is well validated, and biopsies really very seldom needed. The treatment modalities are well defined, and we divide them into curative intended and palliative intended, and Mark will speak more towards that. And we've got the Barcelona criteria that can help us to select patients for appropriate treatment. And at the bottom there, you can see the targets that have been set up for countries where all the treatment modalities are available, curative intended treatment in up to 40% of patients, and then 20% of patients that may or that could benefit from TACE. The prognosis, if you stay within the Barcelona criteria, quite good for the three curative intended treatment modalities with 5-year survivals in most good centers, around 70 or above 70%. We know that there's an advantage in terms of improved survival with TACE, even if we don't cure, and then a very modest improved survival when we use sorafenib. What is the situation in Sub-Saharan Africa? Very different. This is what we not infrequently see, and this is a patient that I looked at together with colleagues at Kenyatta Hospital some years ago. A young man, looking at him, that could be playing for the national football team if it wasn't for this lump on his belly, non-cirrhotic liver, and a very advanced aggressive HCC growing through the abdominal wall into the subcutaneous tissue. The epidemiology in Africa is well recorded. In order of prevalence, you see it there: Western Africa, Central Africa, Eastern Africa, and then Southern Africa. And almost sort of in a perverse coincidence, if you look at the Lancet Commission on Global Surgery's report, and you look at the countries in the world with the highest unmet needs of surgical care, Western, Eastern, and Central Africa, in that order, are the first, second, and third countries when it comes to unmet surgical needs. And I think this is one of the problems that really impact on the management of these patients. The BCLC at stage of presentation. So if you go to high-income countries, just some statistics from Europe. So early stages there, 0A and B, about 40%, with only 14% in the BCLC stage D group. And you can see in Sub-Saharan Africa, it's the other way around. Only 5% of patients will be detected at stage 0A or B, and the vast majority will be stage D, where best supportive care is really what we can offer. When it comes to the treatment in Sub-Saharan Africa, there's not good data on that, but we do get some impression looking at this article from Lewis Roberts' group, where they look at 21 referral centers from the countries you can see on the map there in Africa. So Egypt was also part of this observational study, but if you take Egypt out of it and just look at Sub-Saharan Africa, 1,315 patients, and 0.6% of patients were treated with curative intent, where probably 5% one way or the other could have been treated with curative intent. Also very worrying is, I think, how Africa is overlooked when it comes to research. One would think that in this specific publication exploring the impact of ethnicity and on the molecular biology of hepatocellular cancer, that Africa would be interesting, that there was no work done in Africa on that. And if you just look at the ongoing research in the world, that less than 1% of ongoing clinical trials on HCC are run in Africa. Just to show you where this meeting comes in, it's run under the auspices of the Gastro Foundation, where we started the GI Hepatology ECHO 2020. And under the ECHO, or what we call the GECHO platform, there are already 4 lines of meetings running. There's an endoscopy meeting once a month, there's an IBD meeting, there's a blood management meeting, and there's also a hepatology / pathology meeting. So this will really be the fifth stream under this umbrella. The concept of this meeting, or the format of the meeting, we have discussed with a few colleagues in Sub-Saharan Africa, and this is what we came up with, that we will have a format with a short, sort of, if you want, didactic lecture initially, and then followed by typical cases in the MDT format. And I really want to thank Dr. Onasai Sheaka, Karan Gandhi and Rashid Nashidengo for stepping up and coming with the first three patients we're going to discuss, and also Mark Bernon, that's going to give us a treatment overview on HCC. At the end of the meeting, I hope we've got some time for feedback and next steps. Importantly, I think we have to see this meeting as belonging to all of us that have got an interest and ambitions to increase the fate of these patients on our continent or subcontinent. And we really welcome any feedback on the format. If there's anything that we can change, we've identified a number of topics that we, in the coming months, will discuss. But if there are topics that you want discussed, please feel free. There is a chat facility on the platform. Otherwise, just mail myself, Cheryl and Karan with suggestions. And I think that's my introduction. And it's a real pleasure for me to introduce Dr. Mark Bernon, one of the consultant HPV surgeons here at Groote Hospital in the University of Cape Town. And he will just give us a quick overview of where we stand with the treatment of HCC, a little bit of an overview, but also some African perspectives. Mark, just unmute.
Sorry about that. So my talk's going to focus on the treatments that are available to treat hepatocellular carcinoma, with specific reference to us who work in Sub-Saharan Africa. As Ed already mentioned, we divide the treatment options into those that are done with curative intent, which include liver resection, ablation, and liver transplantation, and then the non-curative treatment options, which are transarterial embolization, of which there are a number of types, and then the medical therapies, which I'm not going to focus on in any detail in this talk. The Barcelona Clinic liver cancer staging system is widely used when trying to stage patients with HCC, and essentially patients are divided into one of 5 groups. As Ed mentioned, in Sub-Saharan Africa, the predominant, about 70% of patients present with stage C or stage D disease. With the introduction of screening programs, there would hopefully be a shift towards patients presenting with earlier stages of disease, where we are able to offer treatment options. At this stage, about a quarter of patients present with intermediate stage disease, and for those patients, TACE is the treatment of choice, and only about 5% of patients present with disease that really can be treated with curative intent. So I often think that when this topic is approached, it's approached with a sort of Western mindset where people start off talking about liver transplantation first. But certainly in our context, I don't think liver transplantation will benefit a significant number of patients, and it's not really widely available. So that's why I'm going to start off talking about the intermediate stage HCCs. It's a very diverse group of patients. So anyone who's you could be Child-Pugh A or B, so it excludes patients who are Child-Pugh C. minimal or no cancer-related symptoms, and the disease is confined to the liver without vascular invasion. You can have 2 to 3 tumors if they're smaller, if they're larger than 3 centimeters, if they're smaller than 3 centimeters, or 4 or more tumors, irrespective of size. And TACE is recommended for all of these patients in the Barcelona clinic staging system. But it started to become appreciated that that's a little bit too simplistic, and it's a very diverse group of patients. And I think this paper that I've referenced here mentions some of the staging systems that break down the intermediate group further according to liver function and the number of liver lesions. And as can be seen there, some of these patients may be candidates for resection or transplant or TACE, and some of them really just benefit from best supportive care. Just give you an example of a patient that we treated with TACE, 28-year-old who presented with obstructive jaundice due to a large central hepatocellular carcinoma. As many of our patients, he is not cirrhotic with a very high Hep B viral load, and after being stented, his bilirubin returned to normal. And we were faced with the CT scan on the left with a lesion that measured 17 centimeters. And after some discussion, we decided to taste that lesion, and you can see the good response a few months after TACE that it decreased to 90 centimeters. Now, this was not done with curative intent, and he survived for more than 2 years. So this is the kind of thing that can be achieved with transarterial therapies. When we consider the availability of TACE in Sub-Saharan Africa, I think it's worthwhile remembering that bland embolization is a good option if drug-eluting beads are not available. And I think the point is to identify clinicians with angiographic experience, so that, in many centers, there'll be people who are doing angiograms, whether that's radiologists or vascular surgeons. And I think for those clinicians, very minimal additional training is needed to be able to perform arterial embolization of hepatocellular carcinoma. Moving on to the potentially curative treatment options, as we mentioned, there's 3. There's ablation, which is either thermal ablation, and we usually use microwave ablation, or what is often very effective if that's not available is ethanol ablation, and that is obviously widely available, resection and transplantation. Now, as you move down towards transplantation, the disease-free survival with these treatments improves, as does the overall survival. But one needs to remember that that comes at the cost of higher complications and higher mortalities for these treatments. So ablation has the advantage of being the least morbid treatment, but it does have the highest recurrence rate. So if you consider the treatment options, curative treatment options, that are going to be more widely available in Sub-Saharan Africa, we're talking about liver resection and ablative therapies. So starting off with liver resection, it's the treatment of choice for non-cirrhotic patients. And as we know, we have a large portion of our patients who are not cirrhotic. The Barcelona clinic staging system, you must remember, applies to cirrhotic patients, and they recommend resection for patients with very early stage disease, and that takes into account the size, so it's small lesions, Child-Pugh A, no portal hypertension, and a good performance status. But I think it's worthwhile bearing in mind that resection is an option for patients with early stage disease and intermediate stage disease. And although the Barcelona clinic staging system is widely applied in the Western world, it's not really applied in Asian countries. If you resect patients within the Barcelona clinic system, you have a 70% 5-year survival. Morbidity of operating on cirrhotic patients is probably double that of operating on non-cirrhotic patients, and often you have to do non-anatomical resections, but it is possible to extend resection criteria even in cirrhotic patients. And just to make the point that liver failure is the biggest cause of post-operative mortality after liver resection, and it's a particular concern when you operate on cirrhotic patients. This is just an example of patients who were resected beyond the Barcelona criteria. And if you look at the first three, it's patients with portal hypertension, patients with multiple HCCs, and patients with large HCCs. The morbidity and mortality was not particularly much higher in that group of patients, and there was a reasonable 5-year survival. So if you extend your criteria, your survival is going to go down. The one group of patients that had a particularly bad survival were patients who had macrovascular invasion. So I think the Barcelona Liver Clinics system say that you can resect patients who are very early stage, but you can certainly resect more patients than that. And there is a role for resection in patients with early stage and even intermediate stage disease, and certainly in patients with non-cirrhotic livers. Moving on to ablation. So the Barcelona clinic staging system suggests this for selected patients with stage A disease, but that's despite the fact that patients with very early stage disease are actually the ideal candidates for microwave or any ablative therapy, because they have a single tumor that's less than 2 centimeters. And we know that those patients have up to a 90% complete response when they're treated with ablative therapy. So that's one of the weaknesses of the Barcelona clinic staging system. Microwave ablation can be performed percutaneously, laparoscopically, or open, and you can extend it for lesions up to 5 centimeters, although as the lesions get bigger, your recurrences do go up. The big problem is if you're faced with a liver, like you can see here, where there's multiple nodules, is accurately identifying where the tumor is to be able to ablate it properly. And I think that's the biggest challenge in these patients. So I think, although they suggest that it's a good treatment option for certain early stage disease, I think it's a very good option also for some patients with very early stage disease. I'm going to mention a little bit about transplants, and there's various transplant criteria that are applied around the world. And obviously the ones that are important are the ones that are applied in your transplant center. The 2 transplant centers in South Africa use the UCSF criteria. As you extend your transplant criteria, your 5-year survival decreases. But I think 2 things to mention is that you don't transplant people if there's extrahepatic disease or if there's vascular invasion, and there's increasing acceptance that you don't transplant people with markedly elevated alpha-fetoproteins, although that's not in these criteria. The Johannesburg group has published the largest series of patients in Sub-Saharan Africa who've had liver transplants, and that was 31 patients, a diverse group of etiologies for the liver disease, and reasonable 5-year survival, acceptable 5-year survival, especially in the patients who were transplanted within UCSF criteria. We have transplanted 8 patients since 2016. The last patient we transplanted was in 2019, and unfortunately our transplant program has been impacted by COVID, but we hope to start transplanting again for HCC soon. And all of these patients are still alive without any evidence of occurrence as of the end of last year. Professor Jonas performed an online survey of HCC management in Africa, and there was a reply from surgeons at 13 centers in various countries, including Nigeria, Senegal, Ghana, Cameroon, Kenya, Uganda, Namibia, and Zimbabwe. And I think the point to make is that all of these modalities are available in these countries, except maybe for PET scan, which is not really that important in the HCC. And all of the treatment modalities seem to be available in a large proportion of these countries, once again, except for really transplantation. So in conclusion, I think you can divide this into the good. So I think the good is the increasing awareness of the mortality and morbidity that's caused by hepatocellular carcinoma in Sub-Saharan Africa. And there's an increasing number of tools that are becoming available to improve the situation, such as hepatitis B vaccination, antiviral therapies that are widely available, and the increasing availability of HPV services. And also, we can only really do better because we have been treating such a small proportion of patients with hepatocellular carcinoma. The bad is the high burden of disease that coincides with limited resources, the inability that we have had to identify patients with treatable HCC, and having proper referral pathways once patients are identified with hepatocellular carcinoma. And then the ugly are divided into two things, and that is the patient that we see on the left, where we see these young patients that present with very advanced hepatocellular carcinoma, where there's really nothing that we can do. And the thing that's really going to improve that is two things: vaccination for hepatitis B and screening programs. And then the other thing that I think is really tragic, that happens a lot, is when this is an example of a pedunculated HCC hanging off segment 6 of the liver, a very easy, simple liver resection that potentially cures this patient. And if that doesn't get offered to the patient, I think that's pretty tragic. So I do think things are potentially coming to a tipping point where lots of new treatments are available, and vaccination for hepatitis B started in many countries. So hopefully we're going to get to a situation where there's less patients with HCC and better services available to treat those who have HCC. So thanks very much. I'm going to stop sharing there. We're going to take questions and comments at the end. We're now going to move on to the case presentations. And the first case presentation is going to be by Onosai Chiako, who's an HPB surgeon in Harare in Zimbabwe, and who spent some time with us in Cape Town. And Onosai, over to you.
Yes, thank you very much, Mark, and thank you very much, the organizers, for giving us this opportunity to discuss some of the cases that we have in our setting. Clearly, with multidisciplinary treatment, team meetings, this will improve patient management. So I'm going to present this patient that I have, a 53-year-old male patient who is a farmer here in Zimbabwe. He's married, and he has never smoked and does not take any alcohol. Presented to us with very benign symptoms of some just vague epigastric and right upper quadrant pain. It was not requiring any analgesia, it was just bothering him, but he has had it for 3 months before he came to us. When we examined him on admission, on presentation, he was a very fit 53-year-old with an ECOG score of 0. His abdominal examination was essentially normal. So he had some lab investigations. He had a full blood count done. His HP was 14, and he had a relative leukopenia with a white cell count of 2.1. and a relative thrombocytopenia. Platelet count was 105 at presentation. His liver function was normal. His albumin was 34. Bilirubin was 10, and the conjugated bilirubin of 6. And his hepatitis screen, his hepatitis surface antigen was negative, and surface antibody also negative. And he had a hepatitis core antibody positive. It looks like he has had exposure to hepatitis B before. His hepatitis C screen was negative. And of note is that his alpha fetoprotein was very high at 24,000. At this point, an ultrasound scan was the initial investigation that was done. It showed a shrunken liver with obvious signs of cirrhosis. And they also noted a multilobulated right lobe liver mass, and he didn't have any gallstones. In view of this picture, we obviously had a diagnosis of hepatocellular carcinoma in a patient with cirrhosis. So we offered the patient an upper GI endoscopy, and there was no varices, and there was no portohypertensive gastropathy. So we proceeded to do a CT scan that has just been projected on the screen. If you can just run it through for me. And this one is the uncontrasted CT scan. The lower lung bases were clear of any disease. And as we scroll down, we actually see the surface of the liver doesn't look exactly smooth. There's some irregularities of the liver surface, and we can actually see that obvious hypodense lesion that is appearing on the right lobe in segment 5, 6, and 7, and some clear irregularities of the liver surface in keeping with cirrhosis. Maybe if you go to the arterial phase. On the arterial phase, we noted that there was quite some enhancement of that lesion with some capsular retraction on the right side there. And of note is that he had the classic normal arterial anatomy. Yeah, maybe if we just go to the venous phase, which also shows very nice, very nice washout of this lesion. Yes. So this is clearly a hepatocellular carcinoma, quite a large one. The measured diameter was at about 10.2 centimeters. And it's quite a large hepatocellular carcinoma, but it's confined to the right lobe of the liver. And there was no evidence of extrahepatic disease. The concern was that of a shrunken liver with a small left lobe. But when we looked at his MELD score, it was, we scored the MELD score at 9. And his child Q score was 6, giving him, classifying him as a child QA, and with an ECOG score of 0. Yeah, so this is the case that we have, and I would be happy to hear how we proceed in terms of managing him.
So I just wanted to, if anyone has any comments, they can raise their hand, or they can place them on the chat, and then we can take them from there. Honestly, what did you, just with regards to the alpha fetoprotein, so alpha fetoprotein above 500 is considered a contraindication to transplantation. What are your thoughts with that, with such a high alpha fetoprotein in someone who's potentially a resection candidate?
I think my experience so far when I came back here is these are sort of the figures that we see with most of our patients. You know, when they've got high alpha fetoprotein is actually very high. These high alpha fetoproteins usually mean there is a very high disease burden, and potential for metastatic disease is quite high. And that's one of the reasons why they would not really quite qualify for transplantation, because even if we didn't see any evidence of extrahepatic disease, there is quite a high possibility that he may have some occult metastatic disease, and that usually disqualifies them from transplant. But when we looked at this, it's quite confined to the right lobe of the liver. The concern though is of a cirrhotic patient with a small left lobe.
Yeah. So I must say my experience with this is that, you know, in some patients you resect it when there's a single lesion with a very high alpha fetoprotein, you resect it or you treat it, and in some patients it returns to normal, and that's a very good prognostic sign. So if you are concerned, I suppose one of the things you could do is taste beforehand and see if the alpha fetoprotein comes down. I'm not saying that you have to do that, but it's potentially an option.
Mark, if I may, I just quickly comment. Honestly, I think it's an interesting imaging that you showed us. There seems to be quite a lot of capsular retraction in this patient that we do see with HCC, but more often with cholangiocarcinoma or the mixed type. But obviously the alpha fetoprotein levels in this patient tips it over into a HCC, probably confirms an HCC. Just tell me, biopsies in these patients, in your environment there, where CT maybe is not all that so widely available, and we don't have ultrasound contrast, do people have to resort to taking biopsies from tumors that are detected on ultrasound to confirm the diagnosis? Obviously, in this patient, it's not relevant, but in general.
Yeah, so I think the general practice here, unfortunately, is that almost all liver lesions get biopsied mostly before they even come to us. So yeah, most of these patients tend to get some percutaneous biopsies by our radiology team. But when you get a patient with a very high alpha-fetoprotein and the classic picture on CT scan, which fortunately for us is available, but mainly obviously in the private sector, but the CT scan is quite available. So I've been trying to discourage the routine biopsying of these lesions, particularly if the alpha-fetoprotein is this high, because to me it's quite diagnostic. And the biopsy, we know it may upstage the disease and yeah.
Yeah, just a question. So I mean, we're going to discuss what is maybe the best treatment for this patient, but just in terms of the treatment options, Mark mentioned that one can, and we sometimes do it in the transplant patients, to get down the alpha-fetoprotein and just to test the waters a bit. Do you have TACE available? And then in terms of local ablation and resection, I mean, you're an HPB surgeon, so you do the resections, but what is the situation with local ablation in your practice?
Good. So luckily, I've got a colleague, an interventional radiologist with a special interest in hepatobiliary interventions. So he does, so TACE is available to us. Microwave ablation is also available to us. The only unfortunate bit is that it's only available outside the state hospitals. But otherwise, if someone can afford it, it's available on the private sector. We've got one interventional radiologist who does this for us here. And
portal vein embolization?
Yes, it's also available. He can also help us with that, yes.
So I don't see any comments or questions from anyone. Maybe you should tell us what you decided to do.
So when we saw him, I was a little bit worried about the future liver remnant because he's a child QA, he's quite fit, and he's young, if you consider 53 to be young. And I thought we needed to be a bit aggressive, but that alpha-fetoprotein was quite worrying. So I referred him to my interventional radiologist, and he did a TACE for us. As you had suggested also, that is an option that we can use. And after the TACE, our alpha-fetoprotein actually came down from 24,000 to about 362 after the TACE. And there was some sort of hypertrophy on the left side, and the tumor size reduced from about 10 to 7 centimeters after the TACE.
Thanks, Mark. I see there's a question. I actually wanted to ask this question, and then Mark Sonder posted. I think that's a very, very important question, and something that we can probably discuss in the context of this patient with hepatitis B. What is the what is the position in terms of post-resectional, well, if for that matter, pre-resectional hepatitis B antiviral treatment if the patient has not been on that? I wonder, I mean, we've got Wendy Spearman here as well. We've got Mark Sonder. Would one of you like to contact and just quickly give us the basics there? Wendy or Mark?
Well, they come in. When I looked at the hepatitis screen, Prof, the surfeit antigen and the core antigen were all negative. The only thing that was positive was the core antibody, which to me probably suggests immunity from a previous B infection. So at this point, we didn't think he needed to be treated, but he stands to be corrected.
Hi, Ed.
Hi, Wendy.
Hi. So, I mean, we would definitely recommend starting on antivirals before surgery. We wouldn't delay surgery to get the HPV DNA level down. And our choice, if the viral load was very high, would actually be lamivudine, which would bring down the viral load much more rapidly than tenofovir. Also, potentially, if the patient is unstable post-surgery with renal dysfunction, then lamivudine would be the safer option, and you can always add on the tenofovir afterwards. And certainly in terms of recurrence post-surgery, it's been shown that if you're on antivirals and your hepatitis B DNA level is suppressed, your risk of recurrence is less. So definitely is something that should be considered, but shouldn't delay surgery or intervention whilst you're waiting for the DNA level to come down or be suppressed.
Wendy, can I just ask a question? If your viral load is undetectable and you just core antibody positive, would you still put the person on antiviral therapy?
I think in the setting of somebody who develops HCC, we would err on the side of actually placing them on. We know that with regeneration, there is a potential for recurrence. So we would recommend still putting them onto antiviral therapy.
And then on a side, Ed, just one thought that I had, in this situation now, TACE was helpful because it showed that surgery is going to potentially be beneficial. But now you're concerned about the size of the left liver. And, could you still do a portal vein embolization if you've done a TACE? I mean, I think if you've done it with drug-eluting beads, you probably can because it's quite selective. But it's just, it could cause problems if you've done if you've embolized the whole right portal vein, right hepatic artery, and then you want to do a portal vein embolization.
I think it could be a problem. There's just a question here from Professor Abate, how to approach an intermediate HCC with a portal vein thrombosis. And I think we probably have to differentiate there between a sort of a tumor thrombosis and a sort of conventional thrombosis, if you want.
So I mean, strictly speaking, if you're going according to the Barcelona liver clinic staging system, once you have, if you have tumor in the vein, then it would fall outside the intermediate group. But if it was just clot, then I suppose it wouldn't. Portal vein thrombosis is a relative contraindication for TACE, but we've certainly done it in numerous patients, and we haven't really had too many problems. Once again, I think it does help if you're using drug-eluting beads and doing quite selective embolization. So it can be done, but I must say, once you start getting a tumor in veins, the prognosis is so bad that, I'm not sure there is much benefit in offering those sort of therapies.
I think one should also just think about which vein it is that is infiltrated and in which direction the flow goes. And I don't know if this has been looked at in detail, but if you get a sort of hepatic vein infiltration with tumor in the hepatic vein, it shoots off into the systemic circulation. Whereas if you get it into a portal vein, it's very unlikely to sort of go against the flow into other parts of the liver, and it's probably going to just affect the segment or the sector that you are in, unless you've got a very central tumor that can seed into the contralateral side as well. I don't know if that is wishful thinking, but I've thought about that. Just Masheko Sechedi, she had a question as well. So Mesh, you can just unmute and just ask your question.
Thank you, Ed. I was just wondering if maybe Wendy or Mark could clarify this for me. So the risk of progression to HCC due to occult HPV infection. And the reason I'm asking is that the stuff I've read is conflictual. So some of the studies suggest that occult hepatitis is a risk factor for HCC and others say not. I mean, I know about the integration of HPV into DNA and that the risk persists, but I was just wondering specifically about occult infection. Thank you.
So in terms of occult infection, it's usually going to be seen in the setting, particularly in Sub-Saharan Africa, when it's either childhood-acquired or mother-to-child transmission. And even if you clear it, it's taken several years. As Mash mentioned, you're going to have DNA incorporation within the hepatocyte genome. And the problem is that that still places you at risk of HCC. So there's no data looking at placing patients who are picked up as having occult hepatitis B because they've been screened for something else, whether you should put those patients onto an antiviral to prevent the risk. So we know the risk exists. We know obviously it's much less compared to somebody who has active hepatitis B replication, but I don't think we can put a risk to it, Mash, in terms, and there's certainly there's no recommendation that those patients should be placed onto antiviral as potential prevention of HCC down the line. I think the main thing comes in when people don't recognize occult hepatitis B and place them on immunosuppression for whatever reason, and then they have a severe reactivation and flare. So I think it's when patients, I mean, we pick it up when patients present with HCC and there's no obvious other risk factor, and then we do the further in-depth screening and pick up occult hepatitis B. But yeah, there are no recommendations to place somebody on occult hepatitis B in order to prevent HCC occurrence down the line.
Great, thanks so much.
Thanks so much. Honestly, I think the discussion here points towards what you've already done is to do a TACE. It has had quite a good response, and then to go on to resect this patient if he's fit, that I understand he is. So thank you very much for that. For that very nice case. And I think we, just in the interest of time, move on to Dr. Karan Gandhi, that's going to present a case from Kenyatta Hospital.
Hi, good afternoon, everyone. Thank you. First of all, to start with, I'd like to thank some of my colleagues from Kenyatta Hospital helping me getting this information. Dr. Mugure Githai, Dr. Malindi from Radiology, and Dr. Dahir, one of the surgery registrars. So our patient was a 27-year-old male patient, a high school teacher who was married with no children. He had a positive history of consumption of locally traditional brew of alcohol for the last 2 years, no history of smoking otherwise, and no other tobacco or recreational drug use. And he was a very active young gentleman with no dietary abnormalities either. He noticed that he had no positive family history of any malignancy or chronic illnesses, and he had no significant previous medical history. So his initial complaint began about 6 months prior to referral to Kenyatta Hospital, where he presented to a peripheral facility with right upper quadrant pain and associated swelling on the right side of the abdomen. It was gradual in onset, the pain was dull and non-radiating, and the intensity was 5 out of 10, which was partially alleviated by over-the-counter analgesia. He had no history of weight loss or alteration in bowel habits, and he was he had an abdominal ultrasound in the peripheral facility that revealed a large hepatic mass, which was biopsied. Just looking back at Onesai's presentation and his comment as well, I think we have a similar issue here in Kenya as well, where the general consensus, where the general practice is to biopsy liver masses as soon as they're seen, which is a practice we need to try and move away from. And that's something that we need to raise awareness for. So our patient was not on any chronic medication, and he was in very good general condition, not pale, not jaundiced, with no edema or finger clubbing, and no palpable lymphadenopathy. And his vital signs were all within normal limits, and he had the proper physiological weight that we read about in textbooks of 70 kilograms. His abdominal examination was, it was normal on inspection, moving with respiration, but he had a palpable hepatomegaly about 6 centimeters below the costal margin, but there was no associated tenderness and no ascites as well. His ECOG performance score is 0, and he was fit and active, like I mentioned earlier. His full hemogram was remarkable, basically unremarkable, and his INR was mildly elevated at 1.38. His renal function and electrolytes were also normal, but he had raised total bilirubin with a mixed picture and an albumin of 41. So that put him in a Child-Pugh score of 7, which is a category B, and in a MELD score of 16. He had screening for hepatitis. He had a negative hepatitis B surface antigen, but unfortunately we didn't have a core antibody done at that point in time. And his hepatitis C was also negative. Unfortunately, looking through the patient's records, there was no alpha fetoprotein done. And then when he presented to Kenyatta, he had these images done upon arrival. So on the uncontrasted scan, we can just appreciate that his liver looks very large. It's difficult to say what side, but of note is that there was no obvious features of cirrhosis on this liver. So the outline, if we go to the contrasted phases, we can actually see that the outline was relatively smooth and regular, and the edges were sharp. But of note is that he's got this very, very large heterogeneous mass occupying most of his right lobe of his liver, with quite significant arterial hyperenhancement and maybe some areas of central necrosis of the tissue. And if we just move slightly cranially, just backwards on this scan, we can notice that he had some satellite lesions also on the left side, particularly in segment 4A, I think. If we just go a little higher, I think you just missed it. If we go a little bit lower down, just about there, yeah, you'll see it better on the portovenous phase. And of note is that he also had variant arterial anatomy as well. He had an accessory left hepatic artery coming off the left gastric artery as well. So he had normal configuration plus this accessory left hepatic. On the portovenous phase, if we scroll downwards, we can see that if you compare this to the arterial phase and to the rest of the liver parenchyma, there's quite marked arterial contrast washout on the portovenous phase. And on this one, you can actually see those satellite nodules a little bit better because it's washed out in segment 4A, what we're talking about. And then if we also just scroll up and down over here, we can notice that there's no portal vein invasion, and there's no invasion of the hepatic veins either. You can see all three hepatic veins inserting into the inferior vena cava cranially. And then if we move on to the delayed phase, we can just notice that just on some of the inferior cuts, we can see around here as well, we can see some capsular enhancement in the periphery as well. So this would be in keeping with a LIRADS 5 hepatocellular carcinoma, because it's got all the typical imaging features of an HCC. And there's no tumor in vein, so this becomes a LIRADS 5 HCC. So if we think about it, with all these imaging characteristics, which are quite typical in a LIRADS of 5, you don't really need a biopsy to diagnose an HCC in this kind of a case. So that's where we were, and in the absence of hepatitis B surface antigen and in the absence of obvious cirrhosis, we were not sure what to attribute the etiology of this HCC to. I think it might need a bit of further look, but we were thinking that it might be related to his alcohol use of the traditional brew.
Thank you very much, Karan. So I mean, this patient is clearly beyond any curative options, and we're probably looking at taste. So just in your setup there, what is the access to taste?
So it's a difficult question. I haven't been back too long, but I know that in the government setting, in state setting, we actually do have some interventional radiologists who are doing taste. For example, so this patient would need a taste, and we had radiologists who are quite keen for that. So we do have them in the state setup. In the private setup, I'm not so sure. I think the maximum we can get in private is a bland embolization at present. But it is something that we need to develop in the near future, especially because a lot of our patients present with this intermediate stage HCC, that we can offer them some sort of therapy.
And then just in terms of the taste, do you have access to beads that is preferred to use now rather than Lipiodol, that is also very difficult to get?
I'm not sure if we use drug-eluting beads, but I assume that's what we use. And then we load them with the chemotherapeutic agents, and then selectively embolize the vessels that are supplying the tumor. If one of my colleagues who are on this meeting have more information, maybe they can help me out over here. But I think that's what we use. We use drug-eluting beads.
Yeah, I saw somebody, Christopher Opio, commented no. I don't know if it was on this particular issue. Maybe it was.
I think he was saying no with regards to the availability of TACE in the private setup. He works in the same hospital as me.
Okay. There's also a question from Olisola Akitikori, and that is, if once you've tasted this patient, what is the role of a CT scan. This was actually posted for, I think, after Onasai's case, after the TACE, where he confirmed that there was a response in terms of a sort of a decrease in the alpha-fetoprotein, whether a CT should also be done. And also in your case, if this patient would go on to TACE, what is the role of repeat imaging after TACE?
I think it's very important to repeat imaging, because then at least we can compare apples with apples. So if we've got a pre-procedure CT scan which shows this large tumor, just what Mark presented earlier as well, he showed pre and post-TACE images of a patient, and you can actually judge the response quite well with a post-procedure CT scan. So I think it does give us a good indication of the response of the tumor to the therapy. Sometimes you might not see a size discrepancy, or you might not see a change in the size, but if you have areas of necrosis, I guess it also depends on the interval after the TACE when you do the CT scan. But I think it does give you a good idea of how well the tumor has responded to TACE. And if you do see necrosis in the tumor, then that's also a good indicator of response to TACE, I think.
Are there any other comments on this case? Thank you very much, Karan.
Karan, just one thing. One of the things that you have to decide, especially in a situation like this where it's palliative, is if you're going to repeat the TACE. And how would you decide if you're going to offer this patient another TACE in a few months' time?
Yeah, I think that's a very valid point as well. So yeah, a repeat TACE is definitely beneficial, I think, for these patients, especially if you get a good response to the initial TACE, and the patient's still not resectable, but you can definitely offer them further sessions of TACE. I think 2 or 3 times is very reasonable to do, especially given that it gives them quite a good survival benefit of at least 20 months extra. I think it's definitely something that should be encouraged.
Okay, thank you very much. There's just a few more comments here from Christopher Apeyu. Surveillance is important, obviously, in these patients with a chronic underlying condition. And then he also wrote that maybe in this patient, the risk or the HCC could be associated with the aflatoxin exposure. And then just finally on this, before we move on, is there a role for immunotherapy in these patients? I must say, we are not involved in that. I think it's pretty experimental. I don't know if there's anybody that wants to comment on that. I know we have got, let's try and see if he's still on, from MSK here, the oncologist. I don't see him on now. But in any case, that's maybe...
with regards to the medical therapies like sorafenib, and I deliberately didn't mention it, that's probably the agent that would be available to us, but it's quite expensive. It has quite a lot of side effects, and certainly in in the trials, the survival benefit was quite minimal. So we used to treat patients with it, but we stopped doing it, and I don't think that it, certainly in our context, has been particularly useful. Maybe some of the newer agents might be different, but that I don't think it's a great loss not having the current medical therapies available.
Okay, thank you very much. We had a third case, but I did discuss it with Dr. Nashidengo that we were not sure how long these cases were going to take, and we're just about out of time. So with permission, Rashid, if it's okay, if we let your case stand over to the next meeting. And we just have a few minutes to conclude, and I just would like to sort of finish off with this is how we're going to go forward. So please, as I said, this is a meeting that is not a Cape Town meeting. It's not a South African meeting. It's a Sub-Saharan African meeting. So please come with suggestions. The contact details you see down there, and we will even mail them out to the attendees. We have a list of topics that we will address in the future meetings, but feel free to suggest any topics. And if you've got interesting patients, interesting cases, feel free to submit them. It doesn't project very well, but as you saw, the form that we will also send out to colleagues is very simple, very quick to complete. What we will ask colleagues to do is if they have got patients and they've sent the form to us, that we will contact them and just arrange for the DICOM files from the imaging to be transferred to us over one of these secure transferring links. We de-identify the patients and then present the imaging from here. That makes it a little bit easier. If we don't have power cuts, our connections are usually quite good, but we also have problems. So if you've got any cases, please submit them, and we can go through them. And as I said earlier, pretty much in line with the whole echo concept, these meetings we hope are instructive. We cannot give sort of specific patient advice, but I think you do get a bit of an MDT feeling coming to the discussions, and it may be guiding treatment. And I think that's what one of the purposes of the meetings is as well. I think it's very good for networking, and it's really very nice to see so many people that I've met before and that have been involved in on different levels in this whole endeavor. And then eventually that we can also document what we look at in these meetings, and hopefully in time can see trends of changes for the better. I don't know if there are any comments from the floor. Anybody with any comments? Otherwise, I see a lot of people have posted some comments here that we certainly will look at. But if anybody wants to unmute and come with any comments, feel free. Otherwise, I think it just remains for me to thank everybody. Sorry, was there anybody?
Yes, thank you all for this presentation. I think it's timely. We have had experience because I moved from Uganda, where we had in our hospital an average of 130 cases every year of HCC. So we saw a lot and did a lot. It is 10 years since we implemented imaging over biopsy. And I think the key issue is to have the radiologists buy up to the imaging and report on the images correctly. And of course, train the end users on how to interpret whatever report comes out. And of course, the differential diagnosis can vary from patient to patient, because I've seen in my poor man's experience that sometimes you may have a differential diagnosis of hemangioma that can present. But if the radiologist is good and the clinician is good, you can sort that one out easily. The other differential is cholangiocarcinoma, which sometimes can confuse you in certain cases. Regarding treatment, most of the patients come in late, and the problem is that they suffer from pain and a mass effect. Usually, most of your chemotherapy may not work in patients, usually, because the masses are so large. And some of them, if they are cirrhotic, you give them the drugs, they end up with a lot of side effects. So we have to take that into consideration. So what we were doing actually was we kind of elevated palliative care, end-of-life care for most of the patients, if it were possible. But the truth of the matter is that you discuss all treatment options with the patient and as an MDT, and give them a chance to make their decision safely, that is. Thank you.
Thank you very much, Christopher, for your comments. Really very valid. And just on the topic of the reporting on these images, Mark, or honestly, I think or it was Karan that mentioned the LIRADS. We do have a talk envisaged for the future on LIRADS as well. I think that all of us should be aware of. And then just quickly looking at the last comments here, Mark Sondrup had just a quick line here on the biologics. That's also going to be addressed in future, and very importantly, palliative care that unfortunately in our situation is probably the most important treatment that we are dealing with at the moment, as most patients will eventually need that. And we will also address that with help from palliative specialists in future talks. So if no more comments or questions, thank you very much for attending. We are looking forward to future attendance. And as I said, we really appreciate contributions and also patients being submitted for discussion in this meeting. Thank you very much.
Thank you.